Welcome to tonight's lecture in the Global Public Health Lecture Series, which is co-sponsored by the Global Public Health Program and the Institute for Health and Humanities. And I want to especially thank all of you who came tonight, because it was really so tempting to just be outside in that beautiful weather, but you came here instead. So I really applaud you for that, and I'm sure you're going to be very happy that you made that decision. So tonight's lecture is by Todd Murdoch. Todd is a pediatric ophthalmologist. He joined the Rocky Mountain Eye Center in Missoula 17 years ago. He has his medical degree from the University of Utah, and he completed his residency and additional pediatric eye care training at the University of Wisconsin. At work, he enjoys helping to improve the vision of children with the help of glasses, eye patching, and surgery when needed. He also enjoys, with his wife and children, many of the things that bring us to Montana, including backpacking, rafting, and fly fishing. So Todd's going to tell you more about the work that he's done in terms of global health in his talk tonight. So.
All right, can everyone hear me okay? Maybe I don't even need a microphone. But, well, I appreciate this opportunity to speak about some eye problems. We're going to cover some pretty important eye problems. Not this particular one, but we will cover some others, and specifically retinopathy of prematurity. And so we'll talk about what that is and how that's affecting the vision of prematurely born babies around the world, and what we can do about it, or what we're trying to do about it. I'll try to give you just the pertinent information and not an information overload. There really is a lot that could be said about this topic, and we'll just keep to the most important points. All right, do the younger members of the audience know who this is? Does everyone know who this is?
I know who that is.
Anyone under 25 can tell me who this is. Stevie Wonder, very good. So very talented musician, songwriter, plays the piano, and completely blind. Does anyone know why Stevie Wonder is blind? There's a hint somewhere on this slide. That is correct. We'll come back to that in just a minute. So, retinopathy of prematurity, in order to tell the story of retinopathy of prematurity, we need to go back about 80 years. This is a slide from the 1933 Chicago World's Fair. And you can see that one of the main displays there was this living babies in incubators. And people are lined up as far as you can see to go in and look at these little babies in incubators. It was such a novel idea. Back then, prematurely born babies did not have a very good survival rate. My own mother was born a few weeks early, was 2.5 pounds, and the family story was that the doctor told the family she's not going to survive the night. Fortunately, she did, but a lot of prematurely born babies did not. And so in the 1940s, it was discovered that if you really gave these prematurely born babies extra oxygen, lots of supplemental oxygen, that their survival rate really went up. And so it quickly became standard of care to just pump a lot of oxygen to these babies. Very soon after that, it was noted that a lot of these babies became blind. And in the early 50s, there was an epidemic of blindness among preemies in the United States. The #1 cause of childhood blindness in the 1950s in the United States was retinopathy of prematurity, which I'll tell you more about in just a minute. But this, what's come to be known as ROP, retinopathy of prematurity, is what caused Stevie Wonder, who was born in 1951, what caused him to be blind. It was in the late 40s and 50s that some medical journal articles started to come out that theorized, at least, that there was something with these high levels of oxygen that was causing the blindness, and that's about as much as they knew back then. Medical care for preemies at that time was really in its infancy. No pun intended. All right, so the pendulum, once this was realized in the 50s that there was all this blindness occurring, the pendulum swung all the way the other direction, and they said, well, we can't be blinding all these babies, so we're going to restrict oxygen. And 20 years later, 1973, a very famous article came out where a researcher looked back at the previous 20 years and found that because of the restriction of oxygen that had been done in order to prevent blinding babies, for every baby whose sight was saved, there were probably 16 who died. So astounding and tragic. And of those who survived, there were many who had cerebral palsy that, had they had enough oxygen, would not have had that. So when that was realized, the pendulum swung back a little bit the other way. One of the problems at that point was that there wasn't a great way to monitor how much oxygen was getting into a baby's system, how much was in their blood. If you wanted to know how oxygenated a baby was, then you either looked at them to see how pink or blue they were, or you withdrew some blood from an artery, sent that blood to the lab, and if you were lucky, it could happen within 15 minutes, but often longer. The lab would be able to do a test and determine how much oxygen was in the blood. Well, if you've ever been around babies who are premature and are on oxygen, you'll know that their oxygen saturation level fluctuates every 10 seconds. It's different. So even though it's helpful to get some of that information back from the lab a half an hour later, it really wasn't very effective in adjusting the oxygen rates for babies. And so some other new technology needed to come around to help monitor the oxygen level in babies' blood. And so something that you've probably all had on your finger was developed in the 70s and early 80s, this oxygen saturation meter. And these are, of course, very widespread now. You can buy them on Amazon for 50 bucks even. And once that came around, it became much more feasible to monitor minute by minute, second by second even, how the oxygen saturation was doing in these preemies. And with that, they were able to more closely titrate the amount of oxygen that they were given. All right, so how does retinopathy of prematurity occur? Why does it occur? Just to orient ourselves here, we've got an eyeball. All of the orange lining in the back of the eye is the retina. You can see some blood vessels that have grown onto the retina. When the eye doctor looks in the eye, this is the view we get. We see this optic nerve right here, and then blood vessels emanating out of that onto the retina. Those blood vessels don't really start to develop until about halfway through the pregnancy. And so a baby who is born prematurely, let's say at 24 weeks gestation, some babies are able to survive having been born almost 4 months early. Those babies, the blood vessels have maybe only had time to grow this far out, and all the rest of the peripheral retina has yet to receive blood vessels. As those blood vessels continue to grow, a preemie is typically going to need extra oxygen. They're going to have other medical conditions that occur that can influence how those blood vessels grow. What can happen is, as the blood vessels start to progress out to the peripheral retina, this is a little different drawing here, a little different perspective, but the blood vessels need to grow out here. This is the peripheral edge of the retina. In this drawing, they've grown this far and then stopped and started to grow abnormally. This is retinopathy of prematurity. And if they grow too abnormally there, then they can cause a retinal detachment. So what's going on at a more basic chemical level inside of the eye that is promoting this blood vessel growth, whether it be normal or abnormal? The main substance that controls this is something that's called vascular endothelial growth factor, abbreviated VEGF, or just described as VEGF usually. There's a little bit of VEGF inside of the eye normally, and that small amount helps the blood vessels grow in a normal way and induces them to grow. It's sort of like fertilizer, if you will, or a substance that encourages blood vessel growth out to the peripheral edge of the retina. What happens in preemies is that a high amount of oxygen, other factors like an infection, lung problems, there are other things that can influence how much VEGF is inside of the eye. If there's too much VEGF, then it will, it's like pouring gasoline on a fire. It's like putting a whole bunch of extra fertilizer on a bunch of weeds. Things start to just grow chaotically and to aggressively. And so the blood vessels, instead of growing in an orderly way, start to become tangled around each other. They grow over exuberantly. They're very fragile and prone to bleed. They tend to scar. If they scar too much, then they will contract the retina and cause a retinal detachment. So who's at risk for having ROP occur? Obviously, it's prematurely born infants, but specifically those who are less than 3 pounds when they're born. And it typically only occurs in babies who are at least 2 months early, so 2 or more months early. Oxygen is a risk factor. Babies who have poorly developed lungs and need higher amounts of oxygen are at higher risk. And then, as I mentioned before, some other systemic factors, how ill the baby is from other reasons, can influence how much ROP develops. There are different stages of ROP depending on how abnormally those blood vessels are growing. I'll give you some examples of that a little bit later. I think this little video really shows you best what happens with ROP. So let's take a look at this. Here we go. All right, going inside of the eye. So this would be at about 23 weeks gestation. Those blood vessels have started to grow out of the optic nerve. They're making their way peripherally. And let's say in this case, the baby needs a lot of extra oxygen, and so there's an increased level of VEGF inside of the eye. And so the blood vessels stop their peripheral growth and they form this ridge. That's a stage 1 type of ROP. If you can see that ridge right there that's forming. If it progresses, if it's not treated, it can start to turn into stage 2 and even stage 3, where blood vessels are starting to grow on this ridge. Again, if it's not treated and it continues to progress, watch it again. Stage 4 ROP occurs, and that's where the retina is starting to detach. And then stage 5 is where the entire retina detaches. So there's stage 4 starting to detach, and then stage 5, it's completely detached. Once the retina completely detaches like that, there is surgery that can be done to reattach it, but it never does function normally again. And so the best you could hope for if a baby had gotten to a stage 5 detachment is the ability to see light and dark. That's the best their vision would turn out, and oftentimes not even that well. So all babies in the U.S. and in most higher income countries are going to be screened for retinopathy of prematurity. And in our country, every country has a little different screening criteria. In ours, it's babies less than 3 pounds or less than 31 weeks gestation when they're born. And it's around the 32-week mark where you start checking their eyes, and every 1 to 2 weeks they'll be checked. So I go over to the newborn ICU over at the community hospital every week or so and check the babies that meet these criteria and see if they have retinopathy of prematurity, and if so, if it's severe enough that any kind of treatment is needed. You keep checking until those blood vessels make it all the way out to the peripheral edge of the retina. You might wonder, well, how many babies, how many preemies end up having severe ROP that needs to be treated? It's about 6%. So a lot of them will develop ROP. Fortunately, most of them it resolves on its own and no treatment is needed. When you're looking in the back of a baby's eye, we've got a special light we use, then a lens that focuses the light. And this is what the ROP looks like. This is stage 3 ROP that you can see there. There's a ridge with some vessels growing out of it. It's kind of hard to see on the screen there, but it's this photo makes me laugh because unfortunately babies are not going to be that cooperative. When they've got a bright light being shined in their eyes, they've gotten dilating drops so that their pupils are large. The last thing they want to do is just look straight into that light and cooperate. Any baby worth his salt is going to resist as much as he can. And so what you actually have to do is put this little eyelid holder in there. There's another little instrument that you move the eye around. You're holding this lens to look. Usually a nurse has to hold the baby's head because they're moving it around, not wanting to be examined. So it is stressful for the babies. It's probably somewhat uncomfortable for them. They tend to cry when it's going on. So you can understand when they have this kind of a response to it. When the ROP gets to the point that a retinal detachment is potentially going to happen, then the treatment for it is typically laser treatment. And so this little arrow is coming in representing some laser that has burned a little spot in the part of the retina that has not yet received blood vessels. The VEGF, the overabundance of VEGF, is coming from the non-vascularized retina. And so if you laser it, it will produce less VEGF. And so when laser is done for this, we put in about 2,000 little tiny laser spots per eye. It takes about an hour to do. And that really reduces the VEGF in the eye and reduces the ROP. This is a video from an ROP screening program in India, which I'll talk more about in a minute, but this is on their website, and I thought did a good job of just showing that you've got this eyelid holder in there, and then when you do laser treatment, you've got this laser delivery system on the forehead that you've got to deliver about 2,000 of those little pulses of laser to do the job. Just in the last few years, another treatment option has become available, and this is injecting a medicine directly into the eye that binds up that VEGF so that it's inactivated, and that works very well. That works even more rapidly than the laser does. There's some potential drawbacks. I won't get into all the pros and cons. It's still somewhat controversial as to which treatment is best out of the injection or the laser. The medicine that's injected, there's kind of an interesting story about it. It's actually a chemotherapy drug that was developed to primarily treat colon cancer. And so when someone has cancer, one of the ways the tumor grows is by growing its own blood vessels. It needs an additional blood supply as it grows. If you can block that blood vessel growth, then you can slow down or stop the tumor growth. It was discovered that that very substance, it wasn't ever developed for this, but if it's injected in the eye, it will stop this overexuberant blood vessel growth in the eye. And it's called bevacizumab is the name of the medicine, Avastin it's sometimes called. This is a video that was taken by Bob Arnold. He's a pediatric ophthalmologist in Alaska, and so this shows briefly just the injection of some of this medicine in the eye. One of the nice things about it is that it's a much quicker procedure. Instead of an hour placing 2,000 laser spots in the eye, this is over in about a minute. So he's putting a little eyelid holder in there to open up the eye. Here's the bevacizumab, 1 syringe for each eye. Little stabilization of the eye, and there's the injection. Got to be very precise in where it's injected so as to not cause a cataract or a retinal detachment. But so it's that quick. I thought I'd just take a second to talk about the issue of quality adjusted life years. I don't know if in the class if this is discussed or not, but health economists will sometimes grade the value or utility of a procedure based on how much extra value or how much quality of life it adds to a person, how many years of that quality of life, and then how much it costs. And so if you look at the procedure, a gastric bypass for someone who's morbidly obese, the quality adjusted life year value for that is $15,000. And it's been suggested by health economists that anything that costs less than $50,000 is a reasonable thing to do. Anything above $50,000 may be costing too much for how much value it gives. So this one is one that passes the test. Cataract surgery passes the test, $2,000. Sometimes when people have a heart that's got an arrhythmia, they'll have an implanted defibrillator. If you look at the just bare bones finances of that, it's one that's above $50,000, and so it may not, from a just purely public health perspective, make as much sense. I would probably want one if I was the patient with the arrhythmia, but when you're comparing procedures, that one is quite a bit higher. One of the lowest I've ever seen is treatment for retinopathy of prematurity. Extremely worth every penny that's spent on it when you consider the number of years of vision that it gives that child and the low cost of the procedure itself. And these are important things for insurance companies. You know, they want to know how much, and the government too, how much bang are we getting for our buck? Any questions about anything so far?
What's the success rate?
Of treatment? It partly depends on how you define success. If success is having normal or nearly normal vision, the success rate of either laser or the injected medicine treatment is probably about 75%. There are a lot of factors that influence that. If you've got a baby that's a 23-weeker, you know, really right on the edge of being able to survive, the retinopathy premature they have, no matter what you treat it with, might end up being bad enough that the outcome's not going to be very good. But if you just look at generally good vision, you know, vision good enough to get a driver's license, for example, it's probably 75%. If you look at vision that is better than legally blind being 2200 or worse, then it's definitely higher, you know, 90%.
Is that Turquoise Lake?
This is High Park Lake in the Missions, so very close to Turquoise. You recognize the mountain range. Yep.
With the drug that's injected, I mean, I'll look up online how they figured that out, and who let them put it in the first time. But I'm assuming it's approved for off-label use in the U.S. And how long has that happened?
Right. The question is about the bevacizumab and how anyone ever had the gumption to inject that in the eye in the first place. It's kind of a long story, but the very brief version of that is that the same company that discovered this, that went through the research and development of it, realized early on that it could be used for the eye. They weren't thinking about retinopathy prematurity, they were thinking about macular degeneration and diabetic retinopathy in adults. And so they made a similar molecule, but a little bit different, and their idea was to sell that in the tiny syringe for about $2,000 per dose. And that's what they've done. They've marketed for that. What they didn't realize is that their very similar molecule that was only for colon cancer and came in a big bottle, you could get about, I don't know, 100 doses out of that big bottle. And so the per dose cost there was maybe $40, $50. And so before it was ever used for babies and retinopathy prematurity, it was used in adults. And there were trials done to compare the expensive drug with the inexpensive drug, and it turned out that they work equally well in macular degeneration and diabetic retinopathy in adults. And so, much to the drug company's chagrin, and despite their efforts to try and prevent it from being used, the less expensive option became more widely used than the expensive one for obvious reasons. And once it was proven to be effective in adults for a very similar muscle growth problem, then there were some studies done on ROP, and then it's just gone from there.
So it's not off-label, it's an approved.
It is not approved officially for that use. The expensive one is. It's gone through the FDA approval process. But there are so many studies that have been done on the unapproved one that from a medical legal standpoint, you wouldn't be found at fault for having used it.
So everybody who's using it, the reasonably priced one is using it off-label.
Yeah.
From a purely economic standpoint, how does the cost of the pharmaceutical treatment compare to the laser treatment that pays for that?
Well, it's a good question. How does the cost of one treatment, laser versus Avastin injection or bevacizumab injection compare? It's a little less expensive to give the bevacizumab. There's a higher need for retreatment with the bevacizumab, and there's a higher need to continue monitoring babies. What's been found is the laser If you're going to have a recurrence of the retinopathy of prematurity, it's going to happen relatively soon, usually within a month or two. And if it hasn't happened by then, it's never going to happen. With the bevacizumab, they found that there are some kids that are several months old, sometimes even a year old, that will, out of the blue, have a recurrence of their retinopathy of prematurity. And if they're not being continuously monitored every month or so throughout all that time, then they can end up blind because no one knew that they were having a recurrence. So you have to factor all those additional exams into the lower cost of the injection.
And initially, because you were talking about costs in the U.S. when they finally figured out what was the problem. So I guess the only places that this was showing up was countries rich enough to have incubators.
Well,
And it wasn't showing up probably in the middle of Africa.
that's a good question. How much ROP is occurring in countries that don't have as advanced of premature baby care? And we'll come to that in just a minute. That's a very good question. That's really the frontier of ROP right now, is actually that issue right there. So telemedicine, you know, the idea of logging into a website or looking on the internet on your phone and looking at a patient's photo or some test results, somehow remotely caring for a patient, is becoming increasingly used throughout the world, including the United States. Why would we need to use that in the U.S.? We've got lots of eye doctors, lots of ophthalmologists here. It turns out with retinopathy of prematurity, there are a number of reasons why there aren't very many ophthalmologists that will screen for it or treat for it. Lots that could be said about that. Briefly, there are very high malpractice awards if a child has a poor outcome with retinopathy of prematurity. There have been juries award the plaintiff up to $10 or $15 million. And so sometimes ophthalmologists see that and they know, well, my malpractice insurance isn't going to cover that level of an award, so they're just like, I'm not going to go there. So that's actually a problem in the U.S., and that dissuades some providers from screening for ROP. It does require some additional training and experience and expertise to do it, and not everyone's willing or wanting to do that. So there actually aren't enough providers, even in the U.S., to screen for ROP. From a hospital's perspective, if they don't have a willing and trained provider locally, it's very expensive for them to transfer preemies to another hospital for that to be done. It's obviously a hardship on the family if that preemie is being sent somewhere and now the family's got to uproot and live away from home in order to be with their child. So a lot of issues that way. In Montana, we started doing some telemedicine ROP screening about 11 or 12 years ago. And I thought I'd just give you the story of how that transpired. So in Montana, we have 3 neonatal ICUs that are of a high enough level that they treat the really premature babies that are at higher risk for ROP. There's one in Great Falls, one in Missoula, one in Billings. And we had, question?
Yeah, I was wondering why there's such a high reward for screening for ROP if there's something that goes wrong.
Why the malpractice rates are so high? There are probably a lot of reasons for it, but I think that one of the biggest is just that when you have a jury looking at a very young child who's now going to be blind or very visually impaired for the rest of their life, like any of us, they're very sympathetic to that child. And so can mistakes be made on the medical side? Sure. But sometimes no matter how well the child's treated, their retinopathy is just so bad that they're not going to have a good outcome. And so in some cases it's felt that it's just that the jury feels sorry for the child and sees an opportunity to try to give them some financial compensation for it.
So this is for screening, though, not necessarily treatment, or?
It could be for any of the above. In screening, if the claim was that the screening wasn't done properly and the retinopathy got out of control and wasn't treated in a timely manner, that would be a potential reason that a lawsuit could be made. And then, of course, if the treatment wasn't felt to be effective enough, that would be another reason. So in Montana, we have 3 neonatal ICUs, really geographically quite distant from each other. And up until about 2006, there was an ophthalmologist in each of these cities who was doing the ROP screening. In 2006, the ophthalmologist in Great Falls moved out of state, and they didn't have anyone to take care of their babies. And so for a short time, I was traveling on their medical transport plane to Great Falls every week or two to do it, but that was not going to be a good long-term solution. And so we had to come up with something else, and we started thinking about telemedicine. When we looked at it, you know, one of the other thoughts was, well, maybe I talked to my colleague and good friend in Billings, Dr. Dan Weaver, pediatric ophthalmologist there, and we were like, well, maybe we could just drive it and kind of switch off. But when you look at the distance, that's a couple of 100 miles between Billings and Great Falls, and you think about the weather in the wintertime, and the roads just was not going to be feasible. When we talked to people back east about it, they're like, oh, that's, you know, just drive from one city to another. But they got to understand that that exact same 200-mile distance would be like driving from Washington, D.C. to New York City. And sometimes you have to talk to them like that to help them realize that it just really was not feasible to do. So we, at that point, there really was not very much telemedicine for ROP screening being done anywhere. There were a couple of pilot programs that had been started in the Bay Area in California and Arizona. There were just 2 or 3 across the country, and not very much published in the medical literature about it. And so one of the questions we had to ask each other, Dr. Weaver and I, was, is this something that we're willing to take on the risk for? This is something where we're kind of being pioneers for. We don't want to set ourselves up for a big malpractice suit here. And we talked to one of the ROP gurus back east at a big university, and he said, you guys are crazy if you take this on. It would be ridiculous. You got your head in the sand or somewhere else, and you're foolish for doing it. And then we didn't know if we would have the time to do it. We had to develop a protocol for how we were going to read these images, how we were going to report back to the Great Falls Hospital about what the images showed, and then when are we going to transfer babies? At what level are we going to say, okay, this ROP is getting severe enough, we need to actually see it in person? So all that had to be figured out. We talked to the people at these other ROP pilot programs and got some ideas from them. And one of the things we realized early on is that it's expensive to set up one of these programs. The special retinal camera that you need to use, or at least at that time that was the main option to use, $80,000. And fortunately, the Great Falls Hospital thought it was worthwhile that they decided to go ahead and get that. But then the question sometimes comes up, well, have there been other advancements? We've got these fancy iPhones that can take pictures of things, and there have been some devices used that you can attach a phone to get some retinal photographs. All sorts of different gadgets you can find on the internet to buy that will give you some kind of retinal photo. There's even some YouTube videos that tell you how to take some PVC pipe, a little super glue. You can see a hacksaw blade in there. You want to wear eye protection if you make this one. And you can make your own little device that will let you see the retina. The problem is it just does not show the retina in the detail that we get when we use the expensive systems. And they're really, I think you'd really be going out on a limb if you used one of these systems right now, just at their current level, to do ROP screening. It just doesn't show you things quite as well as you need to see. We had to figure out who was going to take the photos in Great Falls, how are they going to be paid, how are they going to be trained, and then there had to be some help from the IT people in Great Falls to upload these images where we could securely view them. This is Benefice Hospital in Great Falls, a pretty impressive facility there. This is where it was happening. They see babies all the way down to 24 weeks that are born at 24 weeks. So these are extremely premature babies with significant risk for ROP. This is the little device, not that little actually. This is the device that's used to take the retinal photos. All of the hardware is inside of here, and then you've got this little thing that looks kind of like a pistol or something that's got the camera in it. It goes right on the baby's eye with a little gel to create contact. Here the nurse is putting her thumb in the baby's mouth, just as sort of a pseudo binky. But this would be a typical report that we would receive from Benefice, either Dr. Weaver or I, depending on who's on call for it. And they would give us the birth weight of the baby, how many weeks the baby was when he or she was born, how old they are now, what their oxygen situation is, and then a little more information about the different images of the eyes. Just to give you an idea of what these images look like, this is one that I just pulled. And so there's a little bit of ROP over here. This would just be stage 1, so the blood vessels have grown peripherally. They've stopped right here. They have not grown past this ridge. This is a different baby, stage 2. You can see a little more prominent ridge over here, some blood vessels starting to grow into it. This was actually a baby I remember who was transferred from Alberta down to Great Falls. Apparently they didn't have any room in the neonatal ICU in Calgary and needed to transfer this baby down to Great Falls. And you can see the ROP right over here. It doesn't show up as well on the screen there as it does on the computer, but this ROP, because of how close it was to the optic nerve, was more concerning. So this is a baby I had transferred to Missoula who ultimately ended up needing treatment. This would be stage 3 ROP, where you can see the blood vessels are becoming very engorged, and then you've got blood vessels growing up into the ridge right there. Sometimes the images are pretty blurry, and that's one of the problems with telemedicine, is you don't always get a crystal clear, perfect image. You've got to sometimes deal with subpar images, and there are different ways you deal with that, but that's one of the hurdles to overcome. There's some bad ROP there. Any questions about that part of it? This is also in the missions. This is the outlet of Lost Lake. So, we'll talk about telemedicine elsewhere outside of the United States for ROP in just a minute, but just to kind of give you the snapshot of what ROP, the status of ROP is worldwide. Here in the US, we still have, you know, with all the advances in medical care, there's still approximately 500 preemies that end up legally blind from ROP per year. Why do you think that would be? We've got the lasers, we've got the injection, we've got the good preemie care in these high-level NICUs. Anyone have an idea why we still have that many?
Lack of screening, lack of access to ophthalmology.
It's a good thought, and outside of the US, that is definitely a problem. Lack of screening, lack of access. But in the US, a hospital would not be able to remain accredited if they held on to babies and didn't have someone to screen and treat for them. So, so it's not from lack of access, it's that, yes? Nope, not from lack of insurance coverage.
Born too early.
Born so early. So, you know, 20, 30 years ago, the 26-weekers, the 25-weekers, they did not make it. Now, the 24-weekers, sometimes even 23-week babies will make it. They'll survive. But when you get down to that low of a birth weight, that young of a baby being born, sometimes the retinopathy is severe enough that the best treatments we have are not enough to keep the vision good.
Do all the additional procedures on very small babies and additional complications? Or are some just too little to have those procedures with the additional anesthetic?
Well, a lot of things have been looked at to find out what influences there are that make ROP worse, what makes it better. There was the thought for a while that the fluorescent lights that are in a hospital might worsen it, you know, and be somehow damaging to the baby's retina. It was found that that was not the case. The blue lights, the Billy lights that some babies need, you know, found that that was not worsening ROP. The studies that have been done haven't shown any detrimental effect to therapeutic things that are done for other reasons in the body other than oxygen. And there still is this push-pull with oxygen. There have been studies done as recently as 5 or 6 years ago that looked at, well, now that we have these oxygen saturation meters and we can really precisely try to keep a baby within a certain range of oxygen saturation. Should they be above 90, like we all are normally throughout the day? Should they be a little lower? Is that a little better? You know, before a baby's born, when they're in the womb, their oxygen saturation is probably about 75 to 80. That's just, and so originally the thought was, well, since the eyes develop well in a baby who's born at term, then maybe we should be aiming for 75 to 80. Well, it turns out that's too low for all the rest of the baby's development in a preemie. So there was a study done to compare 90 to 95 versus 85 to 90. And that was just a few years ago. And even in that study, they found out in those that they kept in the 85 to 90 range, there were some babies that didn't make it that otherwise would have if they'd have been above 90. Now their ROP rates were better, but there were babies who didn't make it. And so the general thought now is that you need to keep babies above 90. If you keep them in the high 90s, then you do damage to their lungs. So it's a pretty narrow range, it looks like, 90 to 95 probably where they do best.
And the anesthetic doesn't do anything to their lungs when you're putting them under for over an hour with the laser?
Well, so the question on that was if the anesthetic to put them under for an hour or two to do laser treatment is detrimental. It's not detrimental to their eyes. It can be detrimental to their lungs and breathing if they have to be reintubated. So yeah, that is definitely an issue. It's a good question.
How long are they under for the drug?
They just need a little sedation. They don't need to be completely under for the drug. And sometimes the laser can be done without them under general anesthesia. But yeah, that is a consideration for sure. All right, so if you look at the entire world, how many babies develop ROP yearly? This isn't babies who have ROP that's always blinding, but ROP of any level, 185,000. And about 30,000 of them end up blind per year. So that's current numbers, about 30,000 babies every year going blind from ROP. A small percentage of those are in the US, Canada, Europe, and the latest treatments are being used, and some babies, again, are so premature that's just the best we can do right now. But a larger percentage of those 30,000, if they had the proper screening and the proper care available, their vision could be saved. So the majority of those are ones that we could do better as a medical community. The areas where ROP currently is worst, where it's most in need of better screening and better treatment, are areas of the world where up until maybe 20 years ago, the medical infrastructure was not there to allow a prematurely born baby to survive. And so the babies that were young enough to get ROP just weren't making it, and so there was no ROP. Now, with improvements in medical care in some of these areas, you're seeing this second wave now of ROP developing because the ROP screening infrastructure has lagged behind the ability to keep these babies alive. And so the areas, especially in the 90s where you started seeing this, would be in Russia, China, some places in Central Europe, Romania, some areas in South America, where technology was improving and infrastructure was improving enough, but the ROP was not being recognized and treated. A lot of those areas have improved in the last 10 to 15 years. And so it's really just the areas where the newborn ICUs are on the frontier of starting to help some of these new communities. You aren't having ROP screening match it. So India is a hotbed of this right now. One of the biggest, I'm sure, telemedicine ROP screening program that exists right now is in India. And it's called the KID-ROP program. That's an acronym for the name of the state in India that it's in, Karnataka, I think it is, and internet-assisted program for retinopathy prematurity. Yeah. So this is staggering to me, 3 million preemies a year are born in India. I mean, I can't wrap my head around doing ROP screening for that many babies. In 2008, this Kid ROP program was started, and the model they decided to use, they just decided there are not enough ophthalmologists in India to ever be able to tackle this problem. We need to start training non-physicians to be able to do this. And so they have a very well-established, efficient training program to not only train people to take the photographs, but also in some cases to interpret them. They're in more than 90 hospitals throughout India. They've also expanded to other countries. They've become sort of a resource so that places elsewhere in Southern Asia, Africa, South America, go to these folks for information on how to set up a telemedicine program. I should mention that even, our small program here in Montana, Dr. Weaver and I have given seminars at some of the national pediatric ophthalmology conferences. We've traveled to South America to talk about these things. Dr. Weaver in particular has been very involved in going to other countries to talk about this and be a resource for places that want to set up these telemedicine programs. This Kid ROP program is sponsored by the Indian government, and in babies who develop ROP to the point that it needs to be treated, sometimes they will have an ophthalmologist nearby enough that they can go and either treat with laser or then an injection. Sometimes the babies need to be transferred to a regional hospital. This is a video on their website. I thought it did a good job of showing some of what they do here. So they've got this van, and they actually transport that RetCam retinal photography to the different hospitals that need screening done. Here they are taking some retinal photos. You can see in the background on the screen, the back of that baby's eye. The photos are uploaded. They've even developed some really nice software and an app you can look on your phone or on an iPad and evaluate and determine how that baby's retinas are doing, when they need to be screened again, communicate back to the hospital. So very slick system that they've developed there. Throughout the world, there are 15 million babies that are born prematurely every year. When you look at the breakdown of where those babies are born, less than 10% of them are born in Europe, the US, Australia, Canada. Half of them are born in middle and low income countries, but do have access to some hospital care. And this is the area where ROP screening is most actively being set up. This is where the most good can be done right now. But a third of them are born in areas of the world where they don't have any hospital care at all. So these are babies where they're probably, if they're very premature, they're probably not going to make it. And so ROP, not as big of an issue yet in that group, but as better care becomes available to them, ROP will become more of an issue for them. As I mentioned earlier, the hotspots right now, India, Africa, Southeast Asia, some areas of Latin America. There was a study done just recently in Brazil that kind of highlighted, I think, some of the problems that occur even in an area like Brazil, where there's a lot of medical infrastructure there. Throughout Latin America, if you want to get great training in ophthalmology, a lot of people go to Brazil for it. There's a lot of great medical care there. But they looked at 3 or 4 different hospitals in the neonatal ICUs, and they looked at just the ratio of how many nurses per preemie there were. And there were some hospitals where the funding was just not there to have more than 1 nurse per about 17 preemies. And boy, you think of the amount of care that a preemie needs sometimes when they're having oxygen saturation issues and a million other things that go on with preemies. To be taking care of 17 different babies is impossible. You just cannot do a great job. They compared that to hospitals where there was a 9-to-1 ratio and hospitals where there was just a 2-to-1 ratio, similar to what we would have here in the US. And in the hospitals with the 2-to-1 ratio, they had very similar rates of severe ROP to what we have here. In hospitals with a 17-to-1 ratio, they had 2 or 3 times higher rates of severe ROP, not always fixable with treatment. So in other hospitals, the limiting factor was they didn't have the O2, the oxygen saturation meters. So just simple things that we take for granted are part of the infrastructure that needs to be in place to have the best outcomes for these babies. So I think this is the last slide. The challenges that we face for retinopathy prematurity, having the money to buy the infrastructure in these different hospitals. There are NGOs that are working to help with that. There are government ministries of health that are being educated about the need to support ROP training and funding. A lot of it's just educating. I was on a medical mission trip in Kenya a few years ago, and we were seeing a lot of pediatric patients in this eye clinic, and these parents had adopted a former preemie at about the age of 2 months and brought this child in and said, we don't think that this child can see anything. The baby was now about 8 or 9 months old. And the eye exam showed that this baby had stage 5 ROP, complete retinal detachments in each eye, completely blind. Really not much you can do for that. And on talking with him further, this was a baby who was born in a hospital where they had adequate care to help this preemie survive, but never checked once for ROP. There just wasn't a screening program available. And so a lot of it is educating the hospital administrators, the neonatologists that are keeping these babies alive, that we really need to be looking for ROP. We need to, it's so preventable or so treatable. Just mentioned, like in Latin America, there's a lot of great progress being made. They've had, just in the last 3 or 4 years, they've had conferences and meetings there where they get government officials together with neonatology, with ophthalmology, and come up with programs and plans and enforcement to be able to bring the standard of care up in the hospitals in each of those countries. So we've seen a lot of progress in some areas of the world. Obviously, the best research that could be done would be preventing premature birth in the first place. If you could do that, you could prevent ROP. Less expensive imaging. In India, this Kid Drop program, they did have the funding to be able to buy one of these $80,000 cameras, but a lot of places can't do that. And so if you don't have an ophthalmologist on site, you need imaging, we really need to see better, less expensive, maybe eventually iPhone-related or cellular phone-related screen imaging that can be done. And then in this country and countries where we're keeping these younger babies alive, there's still research to be done to figure out how can we move beyond the treatments we have now to help those 500 babies a year that still are going blind from ROP. Any other questions, comments? Yes, sir.
The Kid Route program, who are the non-physicians performing the screening and the reading?
I think from what I gather, it's smattering of, sometimes it's nurses, sometimes it's just technicians that are hired for that purpose. And I think, if I remember right from their website, I think it's a 90-day or 120-day training program they go through. And they have to certify, they have to reach certain levels of proficiency before they're certified to do it. But I think in some cases it's just a person that shows the ability to do it, and they're not necessarily otherwise in the medical community.
Is that here anyway?
This prominent ophthalmologist back east who had told Dr. Weaver and I that we were crazy for doing a telemedicine program in Montana. It turns out 2 or 3 years ago he started his own telemedicine study and program, and in his he used non-physician readers, and I think primarily they were people with a medical background, but he did do that. It was interesting in the U.S. and the results were fine. So I think there is a potential role for that.
So one thing I didn't get from your talk was how many of these telemedicine interventions do you do? And do you do any beyond Montana, outside the country?
Well, obviously with the internet we could do them from anywhere in the world, but it really has turned out, and I think this is the model that Kid Rop uses, this is the model that we use, and other telemedicine programs that have been developed, is that it's ideal if you can have whoever would potentially be treating the ROP be geographically close. In the US, you have issues with having a state license if you're going to do telemedicine for someone in another state, and malpractice insurance in that state. There are enough hurdles that it's, to my knowledge, it's not done outside of state boundaries in the US. It's where the doctor that's going to be doing the treatment is in the state where the telemedicine is being done. Theoretically, you know, I could, or anyone could be a reader for images taken in Argentina or Kenya if we had to, but there needs to be someone locally to do the treatment if the ROP gets to that point. And so I think it's been found best to have the readers and the treaters geographically accessible. Yes, sir.
So when I think global health and I think of vision, eye problems, what comes to mind is Fred Hollow's Foundation. And I know they have focused on cataracts issues, and they've been able to sort of cut costs to a point where they can save somebody from blindness for about $50 per person. And so my question is, if you, for example, had $1,000 today to donate to a cause, would you pump that money into ROP, or would you still go to cataract issues that are easier to fix? And do you think that this can become as cost effective as that kind of treatment?
Well, that's a big question. The question is, where should research dollars be spent, or where should funding be sent? Should it be more towards adult cataract, where there is a huge need, or should it be more towards ROP? There are plenty of other eye problems too you could add to that list. You know, trachoma. There's a million different things you could add to that list, and which one's number one? I'm going to say ROP because that's, of course, my thing. But if you were only looking at it from an economic perspective, then you might look back at that quality adjusted life year number and say, well, where am I going to get the most bang for my buck? I don't know that ROP, well, I know that ROP organizations are not probably as well organized as cataract. There's not nearly as much ROP in the world as there is cataract blindness. So a lot more has been done on the cataract side, and it's better organized. So, you know, you could say, well, that's where you know that every dollar is going to go to, if you give 1,000 and they've gotten the cataract surgery down to $50 a piece, that's 20 cataracts that you've helped remove right there. But I think in the long run, they're all equally deserving. If you've got someone who's blind and that can be prevented by spending $50 or $1,000, then it becomes hard to make the choice. But I err on the side of ROP, thinking that these are people that are going to be living for another 70 or 80 years, and if we can prevent blindness, that's enormous.
So follow-up. Have you heard of anyone working on maybe artificial intelligence in the analysis of these images, or citizen science kind of?
Yes, that's a great question. Artificial intelligence to evaluate these images and maybe take the human reader out of the equation. There actually are a number of characteristics besides just this stage that I've talked about that you need to evaluate when you look at ROP to determine if it's at the level where treatment is needed. And so, yes, there are algorithms, computer algorithms, and AI, I think, that I've seen research studies done on to try to automate that more. On the studies that are done to compare, let's say, physician readers to non-physician readers, there is a fair amount of variability just from one physician to another in reading these things. And so there's a subjective component that you could hopefully minimize by getting AI to do it. So yeah, it's being worked on for sure. Yes?
If you used a more international model where you use non-medical people to do the reading, like India, I mean, community health workers, all that. How would you pay for it in this country unless you bundled it into the doctors? Yep. I mean, we don't have a mechanism for paying for like that kind of personnel. It's not like it couldn't be done.
Right.
But it'd be tricky.
To have a non-physician reader outside of a study. So far, to my knowledge, it's only been done in a study where you're covered by the, the parameters of that study. I think there are a number of issues. Is a non-physician reader licensed to do that? Do they have a medical license that really qualifies them to do that in the U.S.? Maybe not. What's their malpractice insurance coverage need to be if they're going to be the reader and they're not a doctor? And do they have is it sort of like a nurse practitioner that kind of has a physician oversight of some sort? And there are a lot of details in the U.S. to work out, and then how do you pay them? What kind of mechanism is there for that? Can they bill it to an insurance company? Yeah, that's not really been figured out. I think the study was done with the idea that outside of the U.S. it would be more easily applicable than inside the U.S.
So the doc on the East Coast that's doing it is using other medical people, you said, or is he private, just got a research project?
His is really just research. His is a study. So, for example, in his study, every baby that's checked with telemedicine has a confirmatory exam the old-fashioned way in person.
You gave us a lot of statistics about worldwide, but the one country that usually accounts for a lot of these numbers is China. You didn't mention anything about China. What's the situation in China?
I don't know in detail what the latest is in China, but I think that in the 90s that they had their wave of ROP, and I think it's gotten much better. I was on an IA mission trip in China maybe 5 years ago, and at least in the larger cities, they have really put money into some very impressive eye hospitals. And the model that they seem to be following is having an entire hospital dedicated to taking care of whatever eye problems and whatever age of person it is. So they've got an entire floor dedicated to retinal problems, another floor for cataracts, another floor for pediatrics. These are, 8, 9-story buildings that are just eye hospitals, and they're sort of regional referral centers. And so my impression from talking to the people there was that they've really come around, and probably in the very rural areas, I guess might still be a problem, but I think they've really come around.
Is there a global association of pediatric retina specialists that you meet with your colleagues from around the world?
There are several of them. There's not one that I know of that's the preeminent number one society. But there are a number of international pediatric ophthalmology associations. There are some that are dedicated more to ROP. I don't know of one single one, but there are a number that meet and work on these things.
All right, well, please join me in thanking Dr. Murdoch. I certainly say I've learned a lot, and I also would like to say that I've been to all those links and tweets that he showed in his slide. So next week we have the last in our series. We have Mary and Tim Nielsen, and they're going to be talking about healthcare beyond borders, medical mission in Tanzania. And this will be the last in our series of lectures, but the one thing I want to remind you is immediately following the lecture next week, we're going to have our celebration event. We're going to try to bring together the students and the faculty and the resource people that have been giving these lectures, and have a few snacks as well. So that's going to happen immediately after the lecture next week. So plan to stay for a little while longer. We'll actually move over to what's the room? The president's room in Brantley Hall, right?
Yes.
So we'll plan to be there about this time, 7:45 next week. So thanks again for coming on a beautiful evening.